Hi, I'm Brett-Renes. I'm a psychosexual therapist and an associate lecturer at the University of Sydney. And today is World AIDS Day, and we're celebrating and reflecting on 40 years of HIV. In today's talk, I'll be covering a short history of HIV, then some of the facts, then having a more in-depth look at women living with HIV, and then how HIV is impacting globally, in particular, the Asia-Pacific region. But first, I want to have a moment of remembrance for those who lost their lives due to HIV/AIDS. Today is a day of remembrance. It is a day to remember those who died from the virus. Today, there'll be a lot of statistics, but these individuals weren't just numbers. They were partners, lovers, friends. They were family. They were brothers and sisters, sons and daughters, mums and dads. They were the rich and famous. They were the struggling. They were students, artists and athletes. They were just like you and me. Fate rolled them a destiny that was the stuff of nightmares. But they just didn't lay down and give up. They fought. They fought for the right to be seen, to be heard, and to be included. And they brought together a fractured community and made it a force to be reckoned with. To understand how we got to where we are today, and to appreciate how far we've advanced, we need to understand the past. On June 5th, 1981, the CDC put out a report in their monthly newsletter about a cluster of young gay men in LA with a rare form of pneumonia and who had been relatively healthy up until the time of their illness. They thought the infections were noteworthy as 2 of these young men had died due to the condition, but they didn't think anything huge of it. Within days of this report going out, the CDC was flooded with reports from all over the US of a similar illness affecting healthy young gay men. And because it appeared to be only affecting gay men, this new infection was named GRID, which stood for Gay-Related Immune Deficiency. The numbers in 1981 kept rising and rising, and new infections were appearing overseas. In 1982, Australia had its first diagnosis of AIDS here in Sydney, and a year later, it would have its first death due to it in Melbourne. It was a scary time for everyone, as no one knew how this illness actually spread. Some in the CDC thought it was related to poppers. Others thought it was caused by semen, but no one knew what it was until 1984, when it was discovered that it was a virus. And that virus would soon be known as the human immunodeficiency virus, or HIV. How this virus was passed on was still not known. Fear spread in the community, with reports that the blood bank supply had been contaminated. Hemophiliacs were contracting the virus from blood transfusions. And in the eyes of the media of the time, there was only one group to point the finger of blame at, and that was the gay community. The gay community was at the time, and is still today, the hardest hit by HIV in Australia. Jump forward to 1987, and a treatment is approved in the USA called AZT, a drug originally developed as a cancer drug. It appeared to be effective, but with horrible side effects. But when young men are dropping like flies, what choice did they have? To put it into perspective, in Australia in 1987 alone, 1,297 people were diagnosed with HIV, 536 were diagnosed with AIDS, and 223 passed away. Now, again, to put it into perspective, the queer population of Australia presently is 200,000. At the start of the 90s, everyone thinks that they're getting a hold of this blight. They had worked out how it was spread. They had treatment options, although there were signs that the virus could develop resistance. Governments were investing in campaigns and community organizations to help combat it. And then comes the second wave. Those that had contracted it, the virus in the mid-80s, but showed no signs or symptoms of the infection. Then came a breakthrough. In 1996, saw the development of triple therapy. In short, what this meant was by using 3 different drugs to attack different aspects of the virus replication cycle was able to be stopped, and it made it harder for the virus to become resistant. These early drugs were rather toxic and had a number of severe side effects, but as you will see today, this has changed over time. As you can see, this is a graph of all the deaths in Australia due to HIV/AIDS from 1987 to the year 2000. And as you can see from the columns in pink, the major impact that triple therapy had on the AIDS epidemic. From 1996 is when we start seeing a lot of the game changers. In 1997, approval was received for post-exposure prophylaxis, or PEP. In 2011, the first treatment as prevention studies published their results. In 2014, PrEP trials started in Australia, and 20 years after the birth of triple therapy, the AIDS epidemic is declared over in Australia. From this short and concise history, you can see that we have come a very long way since 1981. So let's go over some of the facts about HIV. The message of test and test regularly is getting through, and the advantage of someone testing at least once a year is that we can pick it up earlier if someone is HIV positive, which is important so that the person can get on treatment earlier. Not that long ago, when someone was diagnosed, doctors would wait until the patient's immune system, which is normally around 800 to 1000 CD4 count, was down around 200 to start medications. And this could take years. However, studies have shown that if a patient starts on treatment early, within weeks of being diagnosed, it increases life expectancy, improves health, and prevents serious illness. Not that long ago, a person with HIV would have to have taken a handful of pills multiple times a day. This is one of the big changes with the medications. Now, most patients take either 1 or 2 tablets once a day. The medications are less toxic, so there are fewer side effects. And most of those side effects do go away after a month or 2. The medication is also more effective at stopping the HIV replication cycle. And where there was once only a few drugs to choose from, now there are a wider variety of medication. And here are just a fraction of those drugs that are available. And new drugs and ways of delivering them are still being developed, including injectables and implants. HIV rates in Australia are low, with only 0.1% of people in Australia currently living with HIV. Rates of new infections are decreasing, with more choices to prevent transmission. I will go through 3 of these. Some of you might be familiar with them, but it's always good to have a refresher. In 1997, it was found through animal studies that ART could be used to prevent the contraction of HIV, but only in a very narrow window period. This led to what we call PEP, post-exposure prophylaxis. PEP means an individual takes antiretroviral medicines after being potentially exposed to HIV to prevent becoming infected. PEP should only be used in emergency situations and must be started within 72 hours after a recent possible exposure to HIV. If you think you may have recently been exposed to HIV during sex or through sharing of needles, you should go to an emergency department and ask your doctor about PEP right away. PEP is taken daily for 28 days. Treatment as prevention, or TASP, is the use of antiretroviral medications to prevent the transmission of HIV to sexual partners. These treatments suppress the levels of HIV in a person's blood and other bodily fluids to undetectable levels. From 2011, a number of studies, including the Australian Opposite Attract study, have confirmed that TASP is effective at preventing HIV transmission. This means there is zero risk of HIV transmission from someone on HIV treatment with an undetectable viral load, or better known as undetectable equals untransmittable. U equals U. PrEP is currently one pill called Truvada, which consists of 2 drugs and is usually taken every day to reduce the risk of becoming infected with HIV. PrEP stands for pre-exposure prophylaxis. The word prophylaxis means to prevent or control the spread of an infection or disease. And that is the aim of getting at-risk individuals to take PrEP so that we can control the spread of HIV. In recent years, there have been some advances with PrEP, including new medications and dosing regimes. Descovy has been around since 2016, and as it's a newer drug, it has less side effects than Truvada. For example, less harm to the kidneys and bone density. Descovy has been approved in other countries for use among gay and bisexual men. However, the data so far has not widely looked at the safe use among women and trans men, so it is still not widely used as PrEP. Descovy has also not been shown to be effective in preventing the contraction of HIV among people who inject drugs. But it is just a matter of time till we have more drugs available for the use of PrEP. The French-based IPIGAY trial demonstrated efficacy for an intermittent dosing regime, also known as on-demand, where individuals took a loading dose of 2 pills anywhere from 2 to 24 hours before a sexual encounter, 1 pill 24 hours after the loading dose, and a 4th pill 24 hours after that. This dosing regime reduces the risk of HIV acquisition by 86%. An Australian study found that around half of all gay and bisexual men in Australia who were taking PrEP were interested in switching to on-demand dosing. And the reasons why people were interested in switching from daily dosing to on-demand included difficulty remembering to take their PrEP, infrequency having sex, and concern about the long-term use. Just like daily dosing, though, it is important that the doses are taken correctly. With treatments and prevention advances, there have been developments in testing, from rapid testing to home testing. While a blood test can pick up HIV in a sample around roughly around 6 weeks after exposure, these tests will not pick up HIV under a 3-month window period. In 2017, the New South Wales Public Health Amendment Bill was reviewed to change the responsibilities for people with certain sexual transmissible infections. This change meant that people living with HIV are no longer required to disclose their status if they are taking reasonable precautions to prevent the spread of the virus. Reasonable precautions in this instance means that the individuals are taking their medications and have an undetectable viral load. Sadly, one thing that hasn't really changed since the early 80s is stigma. Even in the age of PrEP, my HIV positive clients tell me about the abuse they get on dating apps. But I will go into a bit more detail a little later about stigma. And this is a great quote from the seroconversion study of 2016. A lot has changed in 8 years, but HIV hasn't. Treating HIV early lets me lead a healthy, happy life. HIV treatments are now less complex, and we know more about viral loads and sexual risks. I take 1 pill a day, and I couldn't be healthier. In Australia, when we think about HIV, the first things that come to mind are the Gren Reaper ad from the 1980s and gay guys. And while in Australia, the majority of those who contract the virus are same-sex attracted men, globally, women make up the majority of those living with the virus. In Australia, 13% of all people living with HIV are cisgendered women, which roughly equates to about 3,500 women going about their lives, and they just happen to be hosts to this rather persistent virus. However, the experience of living with the virus can be rather different compared to that of cis men. What you can see here are just some of the effects HIV can have on a woman that are different to men. This is due to factors including differences in physiology and endocrinology, and these influence how the virus interacts with the body of its host, as well as the effects the virus will have on the body over time. It also influences how you treat the virus and how the medications are absorbed by the body. In 2006, the World Health Organization put out a Declaration of Human Sexual Rights, which stressed that all individuals have the right to self-determination over their bodies and the rights to information to make informed decisions. And this is particularly important when it comes to pregnancy. One of the great misconceptions is that women living with HIV cannot have children. In Australia, this is not true. Over 2 decades of research has shown time and time again that if a woman is taking her medication and has a suppressed viral load, she has little to no risk of passing on the virus to her unborn child. However, the story to date is not as positive for breastfeeding. Breastfeeding is still seen as a risk of transmitting HIV to a newborn. Often a clinic will supply a mother with baby formula, and this can be something that can be rather distressing for a new mum, as they want that close connection that they have with their newborn child. In 2020, there were 20.1 million girls and women living with HIV around the world. This accounts for 53% of all people living with HIV. And as you can see in this graphic, compared to other countries like South Africa with 4.8 million women living with HIV, Australia, which is the one up in the corner there, has a very small number of women and girls living with HIV. This is a double-edged sword. Yes, as health professionals, we want as few people with an illness or infection as possible. However, with a stigmatized lifelong chronic condition like HIV, small numbers create another problem: loneliness. In Australia in 2020, there were 77 cis female diagnosed with HIV, with 548 cis males diagnosed the same year. Can you imagine how alone these women must feel, not being able to easily find women in similar situations? Let me give you an example. I have just done some work for a small organization that focuses on female survivors of cancer. Their email list was over 8,000 subscribers, which is more than double the total number of women living with HIV in the whole country. And that is just one website. So this leads us to explore just some of the issues that women living with HIV experience. Most gay men probably know someone, either directly or indirectly, who is HIV positive. Many of the leading voices in the queer community are HIV positive. However, this is not the case in the heterosexual community. And even within the queer community, disclosing one's status is a challenge. Imagine how it would be if you are not part of a community that has such wonderful messaging around support, acceptance, and not discriminating against people living with HIV. This is strongly linked to the stigma that is attached to HIV. Just take a moment to think about it. If a friend or a loved one disclosed to you that they had cancer, most people would say, "Oh my God, I'm so sorry to hear that. Is there anything I can do to help?" When it comes to someone disclosing their HIV status, they often are rudely asked, "How did you get it?" HIV has, thanks to right-wing nutters and a media that likes sensational headlines, has been thought of as an illness attached to unsavory behavior. And that's just rubbish. For women living with HIV, fear of disclosure is connected to fear of rejection from friends and family, romantic relationships ending, and they also fear what their disclosure will mean for their children. This fear can also mean that they don't engage with health services out of the fear that they will be discriminated against. And trust me, there are some real shit doctors out there. So their fear is very well justified. And as a result, their overall health suffers. Research has shown that women and girls who live in fear about disclosing or being found out become the victims of their own stress. They develop depression, and women with HIV have higher rates of depression than men. They experience guilt, inferiority feelings, as well as suicidal ideation. The stigma that people living with HIV experience is very real. As I've mentioned before, even within the more accepting queer community, people living with HIV experience stigma. While we would like to think that as a developed nation, we treat women well, in actual fact, we don't. Women do experience minority stress. People may be aware of this, and for others, it might be a new concept. Minority stress is a form of stress seen in people who feel that they are in some way suppressed by the culture they find themselves in. For example, the social expectations that are placed on women, particularly around sex and sexual empowerment. This stress is compounded when women and girls are diagnosed with HIV and they become a minority within a minority group. And this can cause them to experience, as I mentioned, depression, shame, or isolation, and can also lead a person to substance abuse as well as suicide. So what does stigma look like? There are 7 types of stigma that impact people living with HIV, some of which are more prevalent for women living with HIV. The first is self-stigma. And self-stigma happens when a person living with HIV internalizes that public stigma. This is a form of shame, that they feel that they are broken, dirty, unlovable. Public stigma happens when the public endorses negative stereotypes and prejudices, resulting in discrimination against people with HIV. Perceived stigma is the belief that others have negative thoughts about people with HIV. This is a form of distorted thinking, but like a lot of forms of distorted thinking, it is based on experience, be it personal or vicariously. Label avoidance. This is one of the most harmful forms of stigma. This is when a person chooses not to seek help, be it medical or psychological, to avoid disclosing and being assigned a stigmatizing label. Stigma by association occurs when the effects of stigma are extended to someone linked to a person with HIV. So a woman living with HIV may avoid going to a support group or engaging in an organization like Bobby Goldsmith that might be able to help them with housing or getting government support because of that associated stigma. Structural stigma. This is institutional policies and other social structures that result in decreased opportunities for people who are living with HIV. And health practitioner stigma. This takes place anytime a health professional allows stereotypes or prejudice about HIV to negatively affect the patient's care. In a survey of women living with HIV, the researchers found that 69% experienced stigma in their personal lives, 61% experienced stigma in healthcare settings, 60% experienced self-stigma, 56% said that their mental health issues related to stigma made it harder for them to address their HIV-related needs, and 80% said they had experienced some form of violence or trauma. In a study by Sandalowski and colleagues, the researchers looked at how the stigma impacted the lives of women living with HIV. What you see on the screen are the top 5 ways that stigma influenced and changed the lives of these HIV-positive women. They feared and experienced the negative social effects of disclosure, including social rejection, discrimination, and violence. They feared, anticipated, experienced, and adjusted their daily lives to the overt and covert stigmatization they attributed to their HIV infection in both close and distant relationships. For a significant amount, disclosure of their serostatus was a major source of daily stress. They internalized stigma, feeling shame, blame, guilt, worthlessness, dirty, deadly, deviant, and deficient as a woman and as mothers because they contracted HIV. And finally, for a significant amount of the participants, the disclosure of their HIV status to their children and the impact that it would have on their children was a huge concern. There is hardly a nation on earth that has not been hit by HIV. And we are now going to have a brief look at some of the global impact of HIV. Currently, there are 37.7 million people globally living with HIV, with 1.5 million new diagnoses in 2020. In 2020 alone, there were 680,000 advanced HIV or AIDS-related deaths and a total of 36.3 million deaths since 1981. 79.3 million people have become infected with HIV since the start of the epidemic. However, one of the big changes over the last 20 years has been the number of people living with HIV who now have access to treatment. As you can see from this graph, in the year 2000, globally, there was only 770,000 people on treatment. And by 2019, there were 25.4 million people on treatment. This graph gives us a snapshot of the regions of the world and the numbers of people in those areas who are living with HIV. As you can see, combined, the African regions account for roughly 25 million people living with HIV, and the majority of those are women. Keep in mind as well that around 10% of all people living with HIV don't know that they have the virus. So here in Australia, there are about 2,700 people who are HIV positive and don't know it. HIV is a very slow-acting virus, so it could be up to 10 years before they experience any symptoms of the infection. This image shows new infections by World Health Organization regions and whether the rates went up or down for the year of 2019. As you can see, in most parts of the world, the rates of infection went down. For example, in our region, it went down by 12%. In the East and Southern African regions, it went down by 38%. However, in Eastern Europe and Central Asia, the rate skyrocketed by 72%. Currently, in the Russian Federation, there are over 1.3 million people living with HIV. However, only 35% have access to treatment, and over 300,000 don't know their HIV status. As most of you know, the queer community in Russia is constantly under attack. And before I move on to talking about our region, I want to read you a quote by Iskander Yasevez on the issues around HIV in Russia. After the deterioration of relations with Western countries since 2007, the Russian president excluded the HIV/AIDS problem from his public agenda, despite the existence of the data on steep HIV growth in Russia. The Russian president's traditionalism, deproblemization, and silence concerning HIV/AIDS led to the absence of HIV/AIDS issues in the media agenda, the agenda of local authorities, and consequently, the personal agenda of the Russian citizens. The consequences are ignorance, fear, stigmatization of people living with HIV, semi-legal status of needles and syringe exchange programs for intravenous drug users, low antiretroviral therapy coverage, and the continuing HIV epidemic. Indonesia is one of the fastest growing economies in the world. However, like many nations around the world, hardline politicians have been steering the political agenda. And one of the groups in the line of fire is the gay community. With changes in the law that allows police to use unused condoms as evidence to charge them with crimes related to their sexuality, they are taking more and more risks. This has seen HIV rates in this population jump fivefold. As you can see, only 26% of people living with HIV are on treatment. And the first thing that might come to mind is that it might be due to the cost. But since 2004, HIV treatment has been available for free and fully subsidized by the government. Some of the barriers to accessing HIV healthcare include stigma, provider discrimination, confidentiality, and for people living in rural areas, access to transportation. Thailand is a real beacon of hope in the fight against HIV. What Thailand is proving to the world is that with a small and well-managed budget, a nation can stem the tide of HIV in a short period of time. Over the past 5 years, Thailand has seen a decline in HIV infections among men who have sex with men. HIV incidents still remain high in young same-sex attracted men. However, the decline in new HIV diagnoses is associated with increases in HIV prevention programs, pre-exposure prophylaxis or PrEP, and treatment as prevention, TASP. Thailand's success is also the first nation to report the incidence of HIV declining due to the implementation of PrEP and TASP in a low and middle income country. China is one of the world's most populous nations in the world and has one of the fastest growing HIV rates as well. China currently accounts for 3% of all new HIV infections globally. In the early years of the epidemic in China, HIV was predominantly found in intravenous drug users. However, that has been changing, with the main source of transmission now being through sexual contact, and 65% of those infected identified as heterosexual. One of the big issues is around education. Sex ed is not part of the national curriculum. A number of universities in China run Sex 101 classes, and one facilitator of these programs said that for many of the students, it's not just the first time they see a condom, but actually hear about what a condom is. Closer to home, before COVID, university health services at both the University of New South Wales and the University of Sydney were seeing spikes in young Chinese nationals being diagnosed with HIV. If you are interested, there has been some great research into this conducted by the Centre for Social Research into Health at the University of New South Wales. I like Singapore. It is clean, it is safe. However, while it continues to grow and play a more significant role on the world stage, we do tend to forget some of the more draconian laws that are on the Singaporean books. Under the Infectious Disease Act, people living with HIV must disclose their status, not just to their sexual partners, but to their employers and insurance providers. Currently in Singapore, there is no law to protect people living with HIV from discrimination. So if you disclose to your boss that you are HIV positive, you could be dismissed. However, if you are proven to have withheld that information, you could face legal charges. Currently, sex is still the most common mode of HIV transmission in Singapore, accounting for 95% of all new cases. Men who sleep with men account for 58% of all cases, while heterosexuals, both men and women, account for 37% of new cases. However, the data indicates that there could be as much as 27% of the population that may be either avoiding getting testing or deliberately hiding their status. One of the barriers that we need to keep in mind is that in Singapore, homosexuality is still a criminal offence. Therefore, individuals may underreport their gay or bisexual activities. The stigma, institutional prejudice, and legal prosecutions that same-sex attracted men are faced with present real hurdles to early diagnosis and treatment. When an individual is diagnosed with HIV in Singapore, the Ministry of Health must be notified within 72 hours. All of the individual's data is put into a central registry, and this is required so that the individual can access HIV care. However, in 2019, this confidential information of 14,000 people living with HIV that was held by the Ministry of Health was leaked onto the internet, putting these individuals in a very vulnerable position. This impacted a number of my clients. Some had gone back to Singapore, others were here, but on the Singapore registry. You cannot imagine the stress that these guys experienced. And sadly, the stigma and shame was just too much for some of them. Today, I have given you a snapshot of the amazing advancements that have occurred with regards to treating and preventing HIV. I have discussed the issues that women living with HIV face and how HIV is playing out around the world. And while we have come such a long way since 1981, the war against this virus is far from over. While we have reduced the odds of both transmitting and contracting HIV, we still have a long way to go in reducing the stigma that has surrounded HIV since the early days. While we may never find a cure for HIV, and I think one day we actually will, but until then, each and every one of us that is listening to this can leave here today and be able to help reduce the amount of toxic, vile stigma that is aimed at this vulnerable population. What I have learned working in health, first as a nurse, then a health educator, and over the past 8 years as a mental health professional and researcher, is that we can only achieve great change when we work as a team. As individuals who are interested in diversity, sexuality, and sexual health, we have a responsibility to educate both ourselves and others with good, reliable information, to advocate for those that don't have a voice, and to be open to thinking outside the square when it comes to solving challenging problems. Thank you.